Hello, everyone. Welcome back. Let's start with a question. A 68-year-old man is intubated for pneumonia and placed on a CVC with a set respiratory rate of 12 and tidal volume of 450. The patient is tachypnic at 24. Which statement is correct? So looking through this option, the most correct statement there would be all breaths receive set tidal volume. Let's see why. So today we're going to be going to vent 103. In the previous lecture, we've covered vent 101, vent 102. And if you have not watched those previous lecture on vent 101 and vent 102, I strongly recommend that you should watch those videos, because what we're going to be talking about today is going to be a build-on of what we've talked about in the past. Over the next couple of lectures, we'll be talking about ventilator modes. And for the purpose of today's lecture, we're going to be talking about one of the most common modes that we use in the intensive care unit. And this is AC/DC ventilator mode, which is also called assist control, volume control. So the AC there is assist control and the VC there is volume control. So what does AC/VC mean? So the assist control means that the ventilator delivers a full mandatory breath. And this breath is given when based on a preset respiratory rate. So you set your respiratory rate. So based on that preset respiratory rate that you set, and of course, if patient also initiates a breath, then that ventilator will also deliver that full mandatory breath. So that's going to be the assist control. So every breath gets a full support, right? And then what type of support are they getting? So that now comes in with the volume control. So each delivered breath has a preset tidal volume. So it's tidal volume that you set. And that's the breath, that's how the breath will be delivered with volume. So for every breath that either the patient initiates or based on the rate that you set, then that patient will be getting that preset tidal volume that you set. So that means what is not fixed there is going to be the pressure. And that pressure could change based on the lung compliance, as we're going to see later, and the resistance. So let's now move on to what are the key settings in this AC/VC? In other words, in assist control, volume control. So first, you're going to set the tidal volume. And so that will be fixed. And based on our previous lecture, our tidal volume usually ranges between 6 to 860 mg per kg of ID body weight. And if you've not watched that lecture, make sure you watch that lecture so that you can know how we calculate the ID body weight. And of course, if somebody have ARDS, right, you may want to go lower than 6, right, depending on the patient, how severe the patient pathology is. Next, you're going to set your respiratory rate or mechanical rate, which is most of the time represented by F. You're going to set your FiO2 and PEEP. Like we mentioned in the past, both the tidal volume and the respiratory rates, those are going to help with what? Ventilation. And your FiO2 and your PEEP is going to help with oxygenation. So those are the key settings we're going to have on AC/VC. And what's not fixed or what's not set is going to be your what? Your pressure. So pressure is not fixed. And of course, if the compliance of the lung is really poor and you put in a lot of tidal volume, that could make the pressure to what? To go up. So a risk of higher pressures if compliance is poor. So let's now look how this works. So patient breathes, right? And the ventilator senses those efforts. And then what's the ventilator going to do? Because you already set your tidal volume, the ventilator will deliver a full preset tidal volume. And of course, if patient stop breathing, you already have your set rate, right? So the ventilator will still deliver breath at a set respiratory that the rate that you already set, right? And this is just an image, of course, showing the assist control and volume control ventilator mode. So you can see what we set. So we set our tidal volume, our respiratory rate, our FiO2, and our PEEP. So for instance, let's say this patient is generating a respiratory rate of 24. So that means out of these 24, 16 of them are going to be what? Our set respiratory rates, right? So that's our set respiratory rate. And the rest of them is going to be patient initiated, right? So patient is one that is going to be initiating those breaths. But irregardless, either patient initiated or our set respiratory rate, patient is going to get a full tidal volume. So our full preset tidal volume that we set, which is going to be what? 500, guys. Moving on. So after I've set this mode, so what are the things I'm going to be monitoring on this mode, right? To make sure this mode is doing what I want the ventilator to do. So one, we're going to be monitor things that help with ventilation, right? So things that help with ventilation. And like we mentioned, remember our minute ventilation equals tidal volume multiplied by respiratory rate. So I'm going to be monitoring the tidal volume. And I want to make sure ensure that the set tidal volume is delivered, right? And like we mentioned, so what we're targeting, we want our tidal volume to be between 6 to 860 mg per kg of ideal body weight. And of course, if somebody have ARDS, the lower, the better. And of course, if you give too much high tidal volume, that could lead to volume trauma, which we're going to see later. Next is respiratory rate. So you also want to monitor your total respiratory rate. Remember, the total respiratory rate will be the combination of the rate that you set and the patient trigger breath, right? And of course, if the respiratory rate is too high, that could lead to respiratory alkalosis, right? And if the respiratory rate is too high, that will also lead to what we call auto-PEEP, whereby before the patient finish exhalation, the ventilator is going to deliver a new breath to the patient. And because of that, that could lead to what we call auto-PEEP or gas trapping or increase in intrinsic PEEP or hyperdynamic, which we're going to see all of them later. And of course, we talk about the minute ventilation. And as we know that minute ventilation, right, is inversely proportional to your what? To your CO2. So that means if minute ventilation is high, your CO2 will be low. And that's what we mentioned earlier. If the respiratory rate is too high, that could drive the CO2 low. And if the CO2 is low, then we say that the patient have respiratory alkalosis, guys. And of course, if you see any sudden change in your minute ventilation, either your minute ventilation suddenly increase or suddenly decrease, it could suggest maybe there's something wrong with the ventilator, or it could be a patient issue. So for instance, let's say the patient suddenly have increase in minute ventilation. It could be the patient is having fever, and because of the fever, the patient is making more CO2. And then because they're making more CO2, then that increases the minute ventilation of the patient. So the second thing we're going to be monitoring on this mode, right? We're going to be monitoring the pressure, so pressure monitoring, right? So what are the pressure we're going to be monitoring? So we're going to monitor what we call the peak inspiratory pressure, so PIP. And this peak inspiratory pressure, you don't want it to be too high. So you want to keep your peak inspiratory pressure below 35 to 40 centimeters of water. And I'm going to talk about that in details in a second. The other thing we want to monitor is the plateau pressure. And the plateau pressure is the pressure that we measured when we do what we call inspiratory hold. So when you do inspiratory hold, you eliminate the airway pressure, and this will tell you about the compliance of the lungs, and then you want this to be below 30. And then the next thing, you can also, based on that, you can calculate your driving pressure. And the driving pressure is the differences between your plateau and the PEEP, and then you want that driving pressure to be below 15, and we're going to see why in a second. The next thing that we're going to monitor on this mode is oxygenation monitoring. So the easiest way at bedside, you can look at the monitor, whereby you look at the oxygen saturation. And of course, you want your oxygen saturation to be above 92. You can also check a blood gas. So you can do your arterial blood gas or your arterial blood gas. And in the arterial blood gas, it can give us information about the partial pressure of oxygen in the plasma, partial pressure of carbon dioxide in the plasma, and it can also give us information about the pH. And then based on that, we can make adjustment to our settings. So for instance, if you do your blood gas and your PO2 is low, right? So if your PO2 and PaO2 is low, you can either increase your PEEP or you can increase your FiO2. And for instance, let's say your PaCO2 is high, then you can go up on your respiratory rate or your tidal volume, right? So that will help with ventilation. So moving on, guys. And it's important to always check your ABG, especially if you make any vent changes. So after you make a vent changes, you want to repeat your blood gas, making sure patient is still adequately oxygenating and then ventilating okay. And of course, if there's any clinical deterioration, you also want to check your blood gas, making sure patient is still oxygenating and they are still ventilating okay. And the next thing is going to be patient ventilator synchrony. So you want to make sure the patient is synchrony with the ventilator. And the things that we watch out for is the patient tachypnea. Are they using accessory muscle? Are they double triggering, which we're going to talk about later? Or are they having agitation, right? So those are the things that you want to be looking for. Because remember, what we see in AC, because every breath is going to be fully supported, either based on your set respiratory rate or the patient trigger is going to be fully supported, right? The next thing is monitoring for dynamic hyperinflation, which is what we call auto-PEEP or ear trapping. And what are the clues on the ventilator that could tell you that patient is having or maybe developing dynamic hyperinflation? So if the expiratory flow does not return to zero, that could tell you, that could be a sign for that. Or if there's a rising end expiratory pressure and difficult in triggering breaths, because if they have a lot of intrinsic PEEP or what we call auto-PEEP, that could make it very difficult for patient to be able to trigger breaths. And the way we measure the auto PEEP, we do what they call end expiratory hold maneuver. So with the end expiratory hold maneuver, that will give you your total PEEP. And then once you know your total PEEP, you can subtract your set PEEP from it, and that will give you the patient's intrinsic PEEP, right? And then the next thing we monitor for is hemodynamic monitoring. So as we know, if you put somebody on a positive pressure ventilation, that positive pressure ventilation is going to increase what? Intrathoracic pressure. And if that increase the intrathoracic pressure, right, that will increase the right-sided heart afterload. So the afterload on the right side is going to increase, and that will decrease the venous return. And so that's why it's important to monitor the blood pressure and monitor the what? The heart rate. And of course, we want to be monitoring for complications. So complications like things like barotrauma, which can lead to pneumothorax, respiratory alkalosis, and ventilator-associated pneumonia. So if patient is developing worsening oxygen requirement, they're having new fever, increased secretion from the endotracheal tube, that could be suggested that patient is developing ventilator-associated pneumonia. And of course, lastly, it's important for daily assessment. So you want to be assessing them for weaning and liberation from the ventilator, which we're going to talk about later. So now, what's the advantage of this ACVC? So ACVC guarantees adequate minute ventilation because you set your tidal volume, you set your rate, so it guarantees adequate minute ventilation. And the patient do tend to have stable PaCO2, right? In ACVC mode. And what are the disadvantages or complications? So patient could develop ventilator-induced lung injury, which we call VLI, like barotrauma because of increase in peak airway pressure. So for instance, if there's a worsening in the patient lung compliance and you're giving them a preset tidal volume, right? So that tidal volume might be too much and that could increase the pressure in the alveoli, and that could lead to what? Barotrauma. And if patient is very interactive with the vent, so in other words, in addition to your set rate, if patient is also breathing really, if they're having tachypnea, right? So that patient could also be triggering the vent. And as we mentioned in the past, every breath triggered by the patient is going to get a full tidal volume. So that could lead to respiratory alkalosis. So patient breathes rapidly and each breath is fully what? Supported. And of course, patient ventilator dysynchrony, that's also the problem. And some of this could be overcome by putting the patient on sedation. So by having sedation on board, that could overcome some of these ventilator dysynchrony and the respiratory alkalosis. So now let's focus on peak inspiratory pressure. Peak inspiratory pressure, because when you rotate through ICU, intensive care unit, or when you work in intensive care units, at some point they might call you about elevated peak inspiratory pressure. So what are you going to do about it, right? So let's talk about it. So what's peak inspiratory pressure, or PIP? So this peak inspiratory pressure is a reflective of the airway resistance and the lung compliance. So it looks at both the airway resistance and the lung compliance. And we're going to talk about lung compliance in a second because that's also determined by your plateau pressure, right? So if you look at our picture here, so here is the ventilator and the here is our patient, and this is the ET tube connected to the patient, right, in the trachea. And then we can see the trachea and then we can see the airway. So that pressure all the way from the ventilator, right? So from the ventilator all the way to the airway, so that's going to be the airway resistance. And then in the lung, so that's going to be the lung compliance. So summation of both of them is going to be the peak inspiratory pressure. So, and like we mentioned earlier, we want this peak inspiratory pressure to be less than what? Less than 35 to 40 centimeters of water, right? So moving on to the next one, which is going to be plateau pressure. So plateau pressure is usually measured with inspiratory hold. So when you do inspiratory hold, so that means when you at the end of inspiration, you hold it, you press on the button, and when you press on the button, that eliminates the airway resistance. So your airway resistance will be 0 because there's no movement off, and so there's no flow. So the flow there is 0. So at that point, so you've eliminated your what? Resistance. So that means the pressure that will be left is going to be the what? Is going to be the alveolar pressure. So that reflects the pressure in the alveolar. And that's why that plateau pressure also is reflective of the lung compliance. And you want that plateau pressure to be less than what? 30, right? And so if the plateau pressure is high, that could be suggestive that there is what? There is worsening in the lung compliance. So the lung compliance is decreased. So that means the lung is becoming very stiff. So, and if you put a lot of tidal volume there, what happens? That pressure could what? That could increase the peak airway pressure. So increased plateau pressure could be suggestive of decrease in lung compliance, like in the setting of ARDS, or somebody who have pulmonary edema, or if there's a what? Pneumothorax. And as we know, compliance, right? Compliance is the change in volume divided by change in pressure. And what's our change in volume? That's our preset tidal volume, right? That's the tidal volume that we're giving. And our change in pressure is going to be the pressure that you get during when you hold your inspiration, during the inspiratory hold, which is the plateau, minus the PEEP that you set. And that difference is going to be the change in pressure, because that change in pressure is the driving pressure. So that's what's driving the tidal volume into the what? Into the lung. So that will be our driving pressure. So on ventilator, our static compliance will be the tidal volume, which is the change in volume, divided by plateau minus PEEP, guys. So what are the physiologic meaning, right? So if there's high compliance, so that means high compliance means that it's easy for the lung to expand. So the lung will expand easily. And when we say low compliance, that means the lung is stiff. So that means more pressure will be needed to be able to what? Expand the lung, for the lung to expand. And that will happen in the setting of ARDS, like we said earlier, pulmonary edema, pulmonary fibrosis, obesity, or somebody who have what? Pneumonia. And what's the normal adult lung compliance? So usually around 100 to 200. And on the ventilator, a good compliance, you want it anything above 50 is acceptable. And of course, if it's less than 40, that's a poor lung compliance. So let's now see how we're going to troubleshoot. So let's say we are called and say there is an increase in peak airway pressure. The ventilator is alarming that there is a peak, there is an increase in peak inspiratory pressure. So how are we going to be able to troubleshoot this? So the first thing you want to do is to do your inspiratory hold, because by doing inspiratory hold, what's that going to give to us? That's going to eliminate the airway pressure, and that will give us the what? That will eliminate the resistance, and that will give us the plateau, right? So that will give us the plateau. So on the ventilator, there's what we call, there's a button which is the inspiratory hold. So when you press that inspiratory hold, and that will tell you the what? The plateau pressure. So let's look at this graph. So anytime you see a graph, the first thing you want to see is to orientate ourselves by looking at the axis of the graph. So by looking on the y-axis, so this is going to be the airway pressure. And on the x-axis, we have what? We have the time. And if you look at here, so here's our PEEP, right? So PEEP, remember PEEP is what we set the PEEP in ACVC mode. So we have our PEEP being set. And that during inhalation, so that patient inspire, right? So once they inspire, then once they finish inspiring, what do we do? We do what they call inspiratory what? Hold. Remember, by doing inspiratory hold, what happened to the airway pressure? So the airway resistance become what? Airway resistance become 0. Very good. So the airway resistance is going to become 0, right? And then by airway resistance becoming 0, that will give us the what? That will give us the plateau pressure, right? And of course, it's going to be the expiration. So if you look at here, so looking at the here, so the peak of this graph is going to be our peak inspiratory pressure, which is our PIP, right? And then when we do our inspiratory hold, so somewhere around there, when we do our inspiratory hold, then that's going to be our what? Our plateau pressure. So that's going to be plateau pressure, right? And of course, the differences between the peak inspiratory pressure and the plateau pressure is going to be our what? Our airway resistance. So that will be the airway resistance. So when we do inspiratory hold, that means during inspiratory hold, that airway resistance will become what? 0. Because remember, there's no movement of, there's no flow. So because there's no flow, that eliminates the airway resistance. So that's where the airway resistance will be 0. So that pressure that we have at that point is going to be our what? Plateau. And that will be telling us about the compliance of the lungs. Very good. And here we can see the B here. So our B is going to be the differences between the plateau and the PEEP. So that differences between the plateau and the PEEP is going to be the elastic pressure. And that elastic pressure is also the same thing as the driving pressure. And the driving pressure is the difference between the plateau. So difference between the plateau pressure and the PEEP. And that's going to be the driving pressure. So let's see how we're going to apply this information. So if there is an increase in the PIP. So if our PIP is increased, right, but there's a normal in plateau pressure, right? So the peak inspiratory pressure is high. So peak inspiratory pressure is high, but when we check our plateau is normal. So that means the reason why the peak inspiratory pressure is high is going to be because of what? Airway resistance. So it's an airway resistance problem. And then when we look at the airway resistance problem, right? So we can start from the tubing, from the ventilator all the way to the airway. So it could be maybe probably there's a kink, right, in the tubing, right? Or the HME is blocked with a lot of secretion. That could be possible because that could increase the airway resistance. Or maybe the patient is biting down on the tube, because if the patient is away, they could be biting the ET tube. Or maybe there's a big mucus plug. So if there's a big mucus plug, that will also increase the airway resistance. Or if the patient is having bronchospasm, like in the patient with asthma exacerbation or COPD exacerbation. So with airway resistance, so secretion, mucus plug, bronchospasm, kink tube, or patient biting the ET tube. So let's say the peak airway pressure is high, but at the same time, when we do our inspiratory hold, the plateau is also high. Then we know that the reason why the peak airway pressure is high is because of poor lung compliance. So that there's a decrease in lung compliance. And this could be an example of somebody who have ARDS, pulmonary edema, pneumothorax, large pleural effusion, right? Because if there's a large pleural effusion, that will prevent the lung from expanding. Or if somebody have abdominal compartment syndrome, right? So in abdominal compartment syndrome, that prevent the diaphragm from moving down. And because of that, we'll not be able to have that create that negative intrathoracic pressure to be able to facilitate what? Inspiration. So that will also increase your plateau pressure. Or if somebody is obese, remember with obesity, that will also affect that could decrease, that could cause extra thoracic restrictive pathology. So it could cause a restrictive pathology because of the obesity. So what about if there's a decrease in peak inspiratory pressure? So this could be due to ear leak, right? So maybe there's an ear leak somewhere in the patient. For instance, if the cuff of the ET2, right, is blown. So because of that, instead of the returning tidal volume to be coming out through the ET2, right, so it could be escaping around the what? Around the ET2. And that could cause decrease in peak inspiratory pressure or peak airway pressure. So moving on to the next concept, which is going to be driving pressure. So we spoke a little bit about driving pressure. So this driving pressure reflects the lung stress, and is strongly associated with mortality in ARDS. And what's driving pressure? So driving pressure is the differences between the plateau pressure and the PEEP. So that difference between the plateau pressure and the PEEP, that's going to be the driving pressure. And like we said, how do we get our plateau pressure? Very good. So you have to do your inspiratory ode. So when you do your inspiratory ode, that will give you the plateau because that already eliminates the what? Airway resistance. Very good. So that will give us the plateau. And that differences between the plateau and the PEEP. Remember, PEEP is positive and expiratory pressure. So that differences is going to be the driving pressure. And this driving pressure represents the pressure needed to deliver that tidal volume into the lungs, right? And what's the physiologic meaning of this? So this reflects the lung compliance, right? And the higher driving pressure, that means the lung is so stiff that we need the higher pressure to be pushing the tidal volume, to be delivering the tidal volume into the lung. So the higher the driving pressure, that means the poor the lung compliance, or the stiffer the lung is, right? And if the driving pressure is really high and we have to be applying a lot of pressure to drive or to deliver the tidal volume into the lung, then that could increase the risk of the patient for ventilator-induced lung injury. So think of changing pressure as how hard the ventilator has to push the lungs open, right? And our usual target for driving pressure, we want this driving pressure to be equal or less than 15. And a lower driving pressure has been associated with decreased mortality in patients with ARDS and also decrease in barotrauma. And as we know that our driving pressure is the change in volume, which is the tidal volume divided by what? Compliance. So if a patient driving pressure is too high, what are the changes that you can make on the vent to try to bring the driving pressure, to try to decrease the driving pressure? So you can decrease the tidal volume, right? Because if I go down my tidal volume, that could help to decrease what? The driving pressure. So that's one way, right? And then the other way is to try to improve the lung compliance. And one of the ways that you can improve the lung compliance is to recruitment with optimal PEEP. So you can go up on the PEEP to try to recruit the lungs and to try to improve the lung compliance. So that could be one way. So either coming down your tidal volume or going up on your PEEP. So that could help to decrease your driving pressure. Moving on to the last aspects of today's lecture, which is dynamic hyperinflation, which is what we call auto PEEP or air trapping. So auto PEEP is also called intrinsic PEEP. So that's what we refer to as intrinsic PEEP. And this occurs when there's incomplete exhalation. So if there's incomplete exhalation, that means there's still some gas still left in the lungs at the end of exhalation. And then what's going to happen? Then the ventilator deliver another breath. And then before the patient finish exhalation, the ventilator deliver another breath. So as a result of that, the patient is going to start what? Gas trapping, right? Gas trapping. And as the gas trapping, that means the pressure at the end of exhalation. And what's that pressure called? Very good. PEEP, right? The positive end expiratory pressure. So that positive end expiratory pressure will start to what? We start to increase. And that's what we call what? That's what we call the auto PEEP. And if that pressure at the end of expiration start to increase, guess what's going to happen? That will start to increase the intrathoracic pressure. And if the intrathoracic pressure is increased, then that could lead to increase in right-sided afterload in the heart. And that could decrease venous return, and that could lead to hemodynamic instability. So when we look at the pathophysiology, so expiration is too short and air cannot fully leave the lungs. And this is common in patients who have obstructive lung disease. So patients who have obstructive pulmonary lung disease, whereby they're having problem with exhalation, like patients who have asthma exacerbation, COPD exacerbation, or if the respiratory rate is set too high. those patients, they're going to have very short expiration. That means they're going to be what? Gas trapping. So they're not going to have, they're going to have incomplete exhalation. And then guess what? The vents will just keep delivering more tidal volume to them, and they continue to have what? Gas trapping. So what are the physiologic consequences of this? So in terms of respiratory, this can increase the work of breathing, guys. Just imagine breathing with a full lung. The lung is still full with air, and then you breathing on top of that, then that could increase what? Increase work of breathing. And that could make it very difficult to trigger the vent. But in order to trigger the vent, there has to be a what? There has to be a pressure gradient, right? So if there's that pressure gradient, that could make it very difficult to be able to trigger the what? Trigger the vents. And that could also increase your plateau, and that could increase the peak airway pressure. In terms of cardiovascular, so that could increase the intrathoracic pressure, and that could lead to decrease in venous return, and that could lead to hypotension. And even patient could develop a PEA-RS, pulseless electrical activity arrest, especially in patients who have severe asthma. In terms of pulmonary, it could lead to barotrauma. So patient could develop pneumothorax, and they could have ventilator-induced lung injury. So how do we diagnose this? So like we mentioned earlier, so a couple of clues that you can look for is when you look at the expiratory flow, if it doesn't return to 0. So that could be one clue, because when you look at the flow, so for instance, let's say this is our baseline, right? Baseline from the previous lecture, right? So let's say this is inspiration, right? And this is going to be expiration. So ideally it's supposed to return to 0. Then the next breath will be what? Deliver, right? So that's going to be inspiration. So if you start seeing something like this, right? So you can see that one did not return back to baseline before a next breath is delivered. Then that could be suggested that this patient is having what? They might start developing autopnea, right? Also rising end expiratory pressure, that could also suggestive of it. Or patient having difficulty triggering what? Breath. So how do we measure this? So we have to do what they call end expiratory hold. So at the end of expiration, you're going to hold it. And once you hold it, then that will give you your calculate, that will give you the total PEEP. So what's total PEEP? Total PEEP is the one that you set. Remember at the beginning, when we talk about ACVC, you set the PEEP. So that PEEP that you set, plus the one that the patient has generated, the intrinsic PEEP, which is also called the auto PEEP, right? So that combination of both auto PEEP plus your set PEEP, that will give you your total PEEP. So when you subtract your set PEEP from your total PEEP, then that will give you the what? That will give you the auto PEEP, right? So if you look at our graph here, so here we can see our PEEP. So here we set our PEEP, and this is inhalation, right? Exhalation. And you can see, as we continue to see, we can see on this second graph, we can see here that the patients did not fully what? Exhale. They didn't fully, that patient did not fully exhale. And if you look at the pressure there, you can see that the PEEP there has what? Has increased. Our initial PEEP was right here. And if you look at the new PEEP, right? So the new PEEP is somewhere around here, right? So that will be the total. So this is going to represent the total PEEP. So if you subtract our set PEEP, which is right here, from the total PEEP, then that will give us this what? This intrinsic PEEP, which is also the auto PEEP. So moving on, guys. So how can we manage this? So what can we do on the vent to be able to manage this? So on ventilator adjustments, so you can decrease the respiratory rate, because by decreasing the respiratory rate, you are allowing more time for what? Exhalation. And guys, this is the most effective method, right? So keeping the respiratory rates on the lower end will help to allow more what? Exhalation. You can increase the inspiratory flow, right? So whereby the breath is delivered faster. So by delivering the breath faster, so that's shortening the inspiration, thereby allowing more time for what? Exhalation. So that's one way you can do that, right? So you can go from your flow, let's say your flow, your inspiratory flow was at 60, you can go up to maybe 70 or 75, right? You can increase the expiratory time. So you can increase your I to E time, right? So by increasing your expiratory time, so that means you're going to decrease. So the ratio. So let's say your ratio of I to E. So what you want to do, you want to have more what? More. You want to increase your expiratory and decrease your inspiratory. So in other words, when you look at the ratio of I to E, you want to have more expiratory exhalation time than inspiratory time. So you want to aim for longer expiratory time. So for instance, let's say it was 1 to 3, then you want to increase it to 1 to 5. So whereby you have you're spending more in you're having more expiratory time than inspiratory time. You can also decrease the tidal volume, and then lastly, you can use a square waveform. So by using a square waveform, that could speed up the inspiration. Other thing that you also want to address, the airway treatment. So if they're having bronchospasm, so bronchodilator, if they're having asthma or COPD exacerbation, some steroid, and of course suctioning if there's any secretion in their airway. And then lastly, you can also apply a external PEEP. So whereby you can set your exogenous PEEP, so your set PEEP, you can set it to the 2/3 of the auto PEEP. So that auto PEEP that patient has, you can set your exogenous PEEP to 2/3 of that. And that will actually help to overcome your trigger threshold. And if the patient is severely hemodynamically unstable or they have respiratory compromise, it might be safe to just disconnect them from the vents allow them to be able to exhale, and then manually bag the patient to allow full exhalation. And then once their hemodynamic status improve, then you can connect them back to the ventilator with your new adjustment, whereby you decrease the respiratory rate. And then guys, we have come to the end of today's lecture, guys. Let's do some questions together. So the first question, a mechanically vented patient develops rising peak pressure. So our peak inspiratory pressure here, or our peak airway pressure here is 45. So when we do our inspiratory hold, the patient plateau pressure is 25. So that means, remember, our normal plateau pressure should be less than what? Less than 30. So that means this patient has a normal plateau pressure. So if the peak airway pressure is high and the plateau pressure is normal, then that tells me this is a what? A resistance problem. So it's an airway resistance problem. And based on that, the best answer there will be what? Bronchospasm or mucus plugging. So that will be the best answer there. Moving on to the next question. A patient with ALDS on ACVC, the tidal volume is 420, and plateau is 30, and the PEEP is 12. So what's the driving pressure? Remember, we said that driving pressure is the difference between your plateau minus your PEEP. So that will be the driving pressure. So that will be 30 minus 12. And the answer there will be very good, 18, guys. Next question, a ventilated COPD, and don't forget, in these patients, right, you can see here that the driving pressure is high, because our goal is to keep your driving pressure below what? 15 or lower than that. And so for this patient, what are the ways that we can improve this patient driving pressure? Very good. So you can either go down, you can decrease your tidal volume, that's one, right? Or two, you can try to recruit the patient by increasing your what? Your PEEP, right? Moving on to the next question, a ventilated COPD patient becomes hypotensive shortly after intubation. The ventilator waveform show expiratory flow not returning to baseline. So that's suggestive that this patient probably having what? Auto PEEP, or having increased intrinsic PEEP. What's the best immediate intervention? So it's important to decrease the what? Respiratory rate, guys. And then moving on to the last question. A patient on ACVC has a tidal volume of 400 and a plateau of 28 and a PEEP of 8. What is the lung compliance? What's the lung compliance, guys? Remember, I would say compliance is what? Is the change in volume divided by change in pressure. And what's our change in volume? Down to be the tidal volume. And what's our change in pressure? So that to be plateau minus PEEP. So if we plot our number into this equation, so that to be 400 divided by 28 minus 8. So that to be 400 divided by 20. And that's going to be 20, guys. So the answer there is going to be, so the best answer there will be 20. So it looks like we have two answers here, guys. And then we've come to the end of today's lecture, guys. Don't forget to like, subscribe, and share this video with your friends so that we can continue to make very good video like this. And I will see you guys in the next lecture. Bye.